Good afternoon. Thank you for joining today's webinar on supporting people with serious mental illnesses and reducing their risk of contact with the criminal justice system, a primer for psychiatrists. My name is Deirdre Assay. I am a policy analyst at the Council of State Governments Justice Center, and I will be moderating today's webinar, which is hosted by the Council of State Governments Justice Center and the American Psychiatric Association Foundation's Judges and Psychiatrists Leadership Initiative, or JPLI. Before getting started, I'd like to briefly walk through some housekeeping items about the webinar. Anytime during the webinar, you can ask a question by typing it into the Q&A panel at the bottom right-hand portion of your screen. This includes both technical and content-related questions. We will try to reply to technical questions in the chat window as we go. For the content-related questions, we will address them all at the end of the webinar. We will do our best to get through as many questions as possible. If you encounter technical or audio problems during this webinar, please call WebEx Technical Support at 1-866-229-3239. Please understand that there are some technical issues that you may not be able to resolve. For this reason, we are recording the webinar and we will post it on our website and distribute through the JPLI newsletter. We should have the webinar posted online by the end of next week. For today's webinar, we're excited to be featuring three panelists. Dr. Michael Champion is the Forensic Chief for the Adult Mental Health Division at the State of Hawaii's Department of Health. He is responsible for developing and coordinating a statewide system of forensic mental health services, including liaisons with law enforcement, jail diversion, specialty courts, and reentry programs, and maintaining alliances and linkages with the state and county criminal justice agencies. He currently serves as a member of the Work Group on Mental Illness and Criminal Justice and the Committee on Judicial Action at the American Psychiatric Association and the Psychiatric Leadership Group for Criminal Justice Initiatives. Dr. Fred Osher oversees the health components of the Council of State Governments Justice Center's initiatives. He also provides technical assistance to state and local governments across the country seeking to improve their responses to people with mental illnesses and substance use disorders who are involved in the criminal justice system. Dr. Osher has published extensively in the areas of homelessness, community psychiatry, co-occurring mental health, and addictive disorders, and effective approaches to people with behavioral health disorders within criminal justice settings. And Christopher Seeley is the Program Director of School and Justice Initiatives for the American Psychiatric Association Foundation. Prior to his appointment at the APAF, Chris served as a direct therapy intern at Michigan State University Counseling Center. He provided short-term therapy to a diverse client population while also assisting in weekly multicultural and racial awareness trainings. Chris was also the Assistant Community Director supervising and coaching resident directors at Michigan State. Christopher facilitated social skill building groups for at-risk high school students at Star Commonwealth Detroit. The Justice Center is a national nonprofit, nonpartisan organization that serves policymakers at the local, state, and federal levels from all branches of government. The staff provides practical, nonpartisan advice and evidence-based consensus-driven strategies to increase public safety and strengthen communities. The Justice Center operates the Judges and Psychiatrists Leadership Initiative with support from the American Psychiatric Association Foundation. And now I will turn things over to Chris Seeley to briefly talk a bit about the American Psychiatric Association Foundation.
Thank you, Deirdre. The American Psychiatric Association Foundation is the charitable arm of the American Psychiatric Association. The APA Foundation is in the midst of celebrating its 25th year with the focus on creating a mentally healthy nation for all. At the APA Foundation, we know that 1 in 5 Americans experience mental illness in any given year. And the visual on the slide now represents our programs that are not only offered to our APA members, but the general public to support the profession of psychiatry and foster community awareness and engagement through our 15 programs, 25 awards, and 8 fellowships. Some of the program highlights include our Typical or Troubled program that aims to train educational staff in recognizing the early warning signs of mental health and helping them to refer students to appropriate resources. The Stepping Up initiative that works with county leaders to reduce the number of individuals with serious mental illness in our criminal justice system. Our Helping Hands grants that give medical students the opportunity to start or further community-based programs. And our work also extends into the faith-based communities veteran services, and in the workplace with our Center for Workplace Mental Health. I want to thank all of you who are on the webinar today. I want to also thank Deidre and our partners at CSG, and also like to thank Dr. Osher and Dr. Champion as well for being on the webinar today. And I'll send it over to Dr. Champion.
Great, thank you, Chris. This is Michael Champion. It's very good to be on the webinar today with such a large audience to hear about our new primer and learn more about these issues. So thank you very much for attending today. I'm going to be giving an overview of the Judges and Psychiatrists Leadership Initiative, and then giving an overview of how the webinar will unfold today. So first, let me start with the Judges and Psychiatrists Leadership Initiative. And when thinking about this initiative, it's important to consider some of the moving forces that led to trying to get organized in bringing judges and psychiatrists together to do collaborative problem solving. So if you look back over the last 10 or 20 years, what we've seen is that individuals who have a serious mental illness are increasingly coming in contact with law enforcement, increasingly intersecting with the criminal justice system, and in today's day, it is more likely than not that somebody with a serious mental illness will have contact with the justice system. So with that as context, we were aware and hearing that judges were wanting more information on the needs of the defendants in front of them with a serious mental illness. They were wanting to know more about what available treatments were available in the community, and trying to get a sense about who they may partner with to address those needs. So those are the judges. Psychiatrists were trying to understand what were the legal requirements for their patients when they did have contact with the criminal justice system and were involved in some sort of court supervision, and trying to get a sense of how the criminal justice system worked and how they could be effective at addressing the needs of their patients. And communities were looking to leaders to try to solve this issue of mental illness and criminal justice involvement. So there were more and more requests being asked by national organizations for resources to help judges respond well to the individuals that they're seeing before them, individuals with mental illness or substance use disorder. The other issue is that, you know, our field in behavioral health and psychiatry is evolving very quickly, and it's not possible for judges to be able to keep up with the changes that are occurring so quickly, and so the judges needed a connection with experts who could let them know what those changes are and to learn about the services available in the particular jurisdiction. And so at the outset, the hypothesis that we had was that these kind of partnerships and collaborations between judges and psychiatrists are going to create more resources, better resources for judges, and ultimately improve efficiency in the courtroom. So the JPLI was born out of a collaboration between the Council of State Governments Justice Center and the American Psychiatric Association Foundation. And back in 2008, there was a grant-funded project to do a kickoff and develop a mission statement and begin to develop resources and a team of individuals who would train judges and psychiatrists in this model of collaboration. And the mission of the JPLI was to stimulate and support and enhance efforts by judges and psychiatrists to improve really three responses: judicial response, community response, and systemic responses to individuals with mental illness and justice involvement, with the goals of creating a community of informed judges and psychiatrists, to develop trainings and increase the reach of trainings across the country, and to develop educational resources. And the JPLI has a leadership team, and I'm mentioning this because this is a good reflection of that collaboration and pairing. On the leadership team of the JPLI, Dr. Osher and I serve as the psychiatrist in the leadership team. On the judicial side, we have Judge Leifman, who is the Associate Administrative Judge in the 11th Judicial Circuit in Florida, and Justice Zenoff, who is on the appellate court in Illinois. And both Judge Leifman and Justice Zenoff have been national leaders in problem solving around this issue of justice involvement by individuals with mental illness. And you'll see a link here how you can subscribe to the JPLI newsletter. So this slide gives an array of some of the resources that the JPLI have developed. On the bottom array there, you'll see that there are 3 guides. One is for mental health diversion. The other 2 are a guide to mental health jargon, both on the adult side and the juvenile side. In the middle there, you will see a bench card that is for judges to have at the bench to understand what they're observing in defendants who have a mental illness. One of our most recent resources is this judicial guide you see in the upper right, and it's practical considerations related to release and sentencing for defendants who have behavioral health needs. And all the way on the left, you have a judicial bench card associated with that. And that actually was rolled out to judges just last week. Okay, and so the next slide shows the primer that we're going to be talking about today. This is our newest resource that was developed to assist psychiatrists in understanding the issues involved with people with serious mental illness and with the goal of reducing the risk of contact with the criminal justice system. And most of the rest of this presentation on the webinar is going to be related to the content of that primer. And I understand that during the question and answer session, there's going to be a live link that you can click on to review that primer and download it for yourself. Okay, so here's an overview of the rest of the webinar. We're going to be talking about, I'll be talking about mental illness, an overview of the project process, mental illness in the criminal justice system, and then Dr. Osher will be talking about screening and assessment and the risk concept of risk-needs-responsivity, how to screen for it, how to intervene for it in our populations that we deal with. So first, let me talk about an overview of the project and the process of the project that led to the primer. And we'll talk about webinar objectives here. So for you all as participants, we'd like you to learn about this new resource, learn about the content, learn how to access it, have it in your possession so that you can distribute it, and then get you thinking about how psychiatrists can be actively involved in these collaborative partnerships and solutions for our patients, to learn about criminogenic risk and how to assess an individual's risk level and participate with criminal justice partners in assessing that risk and addressing the risk, and discussing strategies to address criminogenic needs of our patients, particularly in community treatment settings where we're seeing them. And just to note, when we refer to patients, we're talking about people with serious mental illness who have contact with the criminal justice system. Okay. So let's talk about the project origins that led to this primer, and what is the main impetus for creating a primer, a resource like this for psychiatrists. So one fact that we have to face is that 1 in 3 Americans has a criminal record, and people with a serious mental illness are more frequently involved in contact with the criminal justice system, and we end up seeing patients like this in our clinics, in our hospitals, and this is particularly the case in public mental health systems. Over the last 20 years, the care of justice-involved individuals has really gone up quite a bit in public mental health systems, and in the public sector. Now, when looking at psychiatrists in our training, typically psychiatrists aren't trained in our medical school training, residency training, to think about criminal behavior or criminal justice involvement, and think about and address both the clinical and the forensic needs associated with an individual's criminal behavior. Typically, when we think of antisocial personality disorder, antisocial tendencies, we're kind of taught, or it's infused into the way that we approach things, that somehow that's other. It's problematic, it's concerning, but it's other, and so a criminal justice agency is going to take care of that. So typically, you don't see that as an issue that we are to address. The other thing is that psychiatrists are rarely familiar with R&R principles, Risk-Need-Responsivity principles, the interventions that are going to help reduce criminal behavior and reoffending. And so Dr. Osher is going to review these R&R principles. And let me say this is a prompt to help me remember that even though I'm saying psychiatrists and this presentation was developed and is being delivered by psychiatrists, really these principles are relevant to clinicians across the board, psychiatrists, psychologists, social workers, case managers who are involved in providing treatment and interventions to individuals with criminal justice involvement. So Project Origin, the JPLI recognized that there's a need for psychiatrists to learn about these principles to support really three things. One is effective recovery for individuals with justice involvement, to reduce criminal justice involvement, and to improve outcomes for those who are involved in the justice system. So a bit about process. There was a convening by web and conference call of an advisory group that included both forensic and community psychiatrists who had a lot of experience in dealing with individuals with justice involvement, and there were very in-depth discussions on what's the best way for community psychiatrists to support patients who are currently in the criminal justice system. What do psychiatrists need to know about R&R principles, and what kind of information is going to be useful for psychiatrists to actually bring to their practice in a variety of settings, private outpatient, community mental health centers, or even practicing in jails, because there certainly are plenty of psychiatrists and other mental health clinicians working in jails and correctional settings. Our goals for the project included having this tool and primer that was very practical in educating community psychiatrists about R&R principles, giving practical strategies for collaborating, incorporating justice history and criminal justice involvement into routine screening and assessment, and integrating criminogenic risks and needs of patients into comprehensive treatment plans. And the goals are to provide information on R&R and support patients in providing for both the clinical and forensic needs, and addressing the criminal justice issues that they're grappling with as one component of supporting recovery. Another goal was to identify interventions that are going to be helpful for reducing the risk of being involved in the justice system moving forward, and encouraging collaboration, as we've described, which is really the model of the JPLI, judges and psychiatrists, or judges and mental health clinicians working together. So in the next section, I'll talk about mental illness in the criminal justice system. So if you look at the statistics and the numbers over the last 30, 40 years, you see the trends that's on the screen right now. The total numbers of individuals that are under correctional supervision has gone up at an alarming and increasing rate, and it's tabled out a bit after the year 2008, but is still very high. What you see underlined is the totals, those individuals who are on probation or parole in the community and community supervision, or who are in jail and prison. And we think that if you see some of the tabling out after 2008, and some of the reductions may be related to, in certain jurisdictions, reclassification of drug and property felonies as misdemeanors, or adjustment of three strikes laws, and other sentencing reform to try to address the skyrocketing numbers of people in correctional supervision. So why do we do the work that we do? Why is it important to do the work that we do? And as clinicians, get outside of our comfort zone and dealing with justice-involved individuals, with thinking outside the box about innovative treatment. It's because there's, if you look in a year's time, there are 2 million arrests of people with serious mental illness, and about over 500,000 individuals with serious mental illness in correctional facilities, and close to 1 million in some kind of community supervision. So every year, about 1.5 million individuals with serious mental illness involved in the criminal justice system, and a number of those, a large number of those, are individuals who have minor crimes, like sleeping in public, or being in a public park after hours, or urinating in public. And certainly that doesn't tell the whole story, but when you think that individuals with minor charges come in contact with the criminal justice system, they're at risk of needing further forensic evaluations, fitness to proceed, or competency to stand trial, and other kind of evaluations that tap into public mental health sources, which is a challenge for each state to address. So this is a crisis. It's very difficult to miss. It's in the headlines every day. Jails around the country are struggling with the proportion of individuals with mental health issues under their care. And you'll see a headline down there at the bottom: nearly a third of county inmates require medications for mental illness. In the Columbus Dispatch is a headline about individuals with mental illness staying in jail longer when they are detained there. The numbers show that people with mental illness are overrepresented in our jails. So if you look at the general population, 4% have a serious mental illness. In jails, it's 17% have a serious mental illness. And of those individuals with serious mental illness, 72% have a co-occurring substance use disorder. And so we're seeing that there's a phenomenon over the last 20 years where individuals are coming in more and more frequent contact with the criminal justice system and getting arrested and being placed in jail. And what are the factors driving this crisis? We see, particularly with the economic downturn, more and more limited access to mental health care in communities, disproportionately higher rates of arrest. When they go into jails and prisons, they stay longer than their peers that are not mentally ill. There's a higher recidivism rate for individuals with serious mental illness. Those individuals with serious mental illness have more criminogenic risk factors, and Dr. Osher will talk about that in detail. And there's a low utilization overall of evidence-based practices to reduce criminogenic risk and needs utilizing this population. And so that's a good segue into Dr. Osher. Talking about risk, needs, and responsivity and screening and assessment. So I'll turn it over to you, Dr. Osher.
Thank you, Dr. Champion. And again, let me add my thanks to others for all of you taking time out of your busy days to be here in a discussion about an omnipresent tragedy on our American landscape. And that those of you in communities, if you've had a chance to go into our county jails, you will recognize them as a place that you wouldn't want to spend a lot of time in. And far too frequently, individuals with serious mental illnesses that don't pose a particular risk to public safety end up spending a lot of time there. And we know that jail separates one from treatment providers, represents a break in continuity of treatment, and there are a lot of collateral consequences to either being charged and spending time in jail or being convicted and living with those sentences. What Dr. Champion did in the last segment was to highlight the factors that are associated with this overrepresentation of people with mental illnesses in the criminal justice system. And that, you know, we are frequently asked, well, is it because they're more violent? Isn't it true that people with mental illness commit more dangerous crimes? And we know that despite the high-profile media events that most crime is committed by people without mental illness, and most people with serious mental illnesses aren't criminals. Nonetheless, for those individuals with mental illness that find their way into the criminal justice system, we want to be mindful of pathways in so that we can design appropriate supports and responses to mitigate the likelihood of their return with the high recidivism rates that Dr. Champion had outlined for you. And it used to be thought that it was simply a matter of getting people with serious mental illness treatment, and that those untreated psychotic disorders were really driving the overrepresentation. And it turns out that it's a little bit more complicated than that. And it has been for that reason that we wanted to highlight in our primer the risk-need-responsivity paradigm. Within this paradigm, what we have learned is that individuals with mental illness get into trouble, oftentimes not simply related to their symptoms of mental illness. This is one of several studies that have highlighted that fact. This comes from Peterson and colleagues that went into a Minnesota jail and looked at over 400 individuals that were diagnosed with schizophrenia or schizophrenia spectrum disorders, and then asked them in extensive interviews, well, how is it that you ended up in jail? Why are you here? What were you arrested for? Within that interview, what they found with this group is that really only 7.5% were there directly related to their mental illness. So they had schizophrenia. They may have not been on medication. They had auditory hallucinations. It told them to hit someone. They hit someone, and they were arrested. So that's direct and causally related to one's mental illness. Another group, another 10% or so, got there related to their mental illness, unable to work, living in the streets. The individual needed food, went into a store, shoplifted, and was arrested. So that, if they had a better treatment for their mental illness and fewer symptoms, they probably would be able to join our workforce, and that arrest would have been mitigated that way. That said, this graph highlights that over 3/4 of individuals are there not because of their mental illness, and it begs the question why, and that it turns out that they are there for factors that are very similar to the rest of people who get in trouble with the law. They make poor choices, use poor judgment. And so we call, the factors that are associated with arrest criminogenic risk factors. It's a word that is not in the Webster's Dictionary. It's a word that we in the behavioral health field weren't asked to vote on. Sometimes there's pushback around it in that it sounds pejorative, and it is, yet our criminal justice partners have over 2 decades of literature in which they've looked at factors that lead to arrest and have boiled them down to a smaller set of principal factors, and we call them the central 8. And that when we're talking about criminogenic risk, I think it's important that we not confuse it with the type of crime that the person is charged with or committed, whether or not they're going to show up in court, whether they are dangerous or not. These are all very important dimensions to consider, but they're not what we mean by criminogenic risk. It isn't where they get classified and placed within an institutional setting, but when we talk about criminogenic risk, we're referring to how likely is it that a person is going to commit a crime or violate the conditions of their supervision and return to jail or prison. That is criminogenic risk. And what we know is that it's possible to measure risk and to get a predictive value of how likely that individual may end up in jail or prison. And we measure criminogenic risk using two principal categories. That is, static factors that are unchanging. They relate to the individual's history and demographics. And importantly for our conversation today, dynamic factors. Dynamic in that these are conditions that are changeable and that with appropriate interventions can be changed in a positive direction to mitigate the likelihood of subsequent arrest. By static factors, what I'm referring to are the criminal histories, including numbers of arrests, the numbers of convictions, the type of offenses, their current charges, very important, their age at first arrest. The younger you started in criminal activity, the more likely you are to continue. Their current age, younger people more risky than older individuals. Their gender, men more risky than women. And as I mentioned earlier, the dynamic or central 8 risk factors. So as we take a look at these, they're familiar to us. That is that substance abuse, high on the list, as Dr. Champion highlighted in that graph on the expanding correctional population. Our current policies as it relates to drugs have fueled a lot of arrests for possession, sales, use, and destabilizing behavior, and it is a significant risk factor. So when we're talking about those individuals with serious mental illness, the modal individual, as Dr. Champion highlighted earlier, has a co-occurring substance use disorder. The next 4 would fall into a category that we might historically have listed or identified as associated with personality disorders, particularly antisocial personality disorder. And in the old DSMs, we might have actually put this on axis 2. But these factors include their history of antisocial behavior, their antisocial personality patterns that they demonstrate interpersonally and in their interactions with others. Antisocial cognition is not having the right thinking that goes along with this. It's nobody's guarding that firewood. I've got a truck. Let me pile it in the back. Maybe I'll get away with it. Antisocial associates, hanging around with the wrong folks, the wrong people. And then the last 3, I think, are pretty familiar to our audiences. That is family or marital discord, poor school or work performance, and few leisure and recreational outlets. And that one of the central themes that we want to highlight today is that the behavioral health field has done a pretty good job. It's our bread and butter looking at the bottom 3 dynamic factors. We're increasingly within our behavioral health settings and within mental health settings attending to co-occurring disorders like co-occurring mental illness and substance use disorders. We haven't been so terrific about specific interventions that target the 2 through 5 dynamic risk factors, and that's what we want to spend a little bit more time on today. What we do know is that those individuals with criminal justice contact that come into our jails, when they're assessed, have more of these central 8 dynamic risk factors than the other non-SMI individuals within those correctional settings, and that these predict recidivism more strongly than mental illness. You'll note that mental illness wasn't in the top 8 as a criminal justice risk factor, and that it is the case that with the strong co-occurring prevalence, and that if you have a mental illness, you're 3 times as likely to have a co-occurring substance use disorder, that substance use is driving a lot of activity that ends up getting people in trouble. That what we understand then from awareness of these factors can be summed in the risk-need-responsivity paradigm, in which I'm going to just review briefly the 3 R and R principles, starting with the risk principle, in which we understand that if you have scarce resources, you really want to make sure that you're focusing on those individuals. If you're particularly the outcomes you care about are public safety, those individuals that pose the greatest risk to communities. We've learned this the hard way over time, and I share with the summary slide with you. This is from a study that was done several years ago in Ohio. In the state of Ohio, they were using halfway houses for people that were leaving correctional settings, state prisons, and returning to community. And these community correctional facilities people were assigned to go there for some period of time prior to then being released back to their communities of origin. What they looked at retrospectively is that those individuals that were sent there that had then a risk score developed retrospectively were found to do very poorly if they were in this low criminogenic risk arena. So that for those individuals under measurement that were higher or moderate risk, they ended up with their participation in these halfway houses returning to prison at rates less than those that didn't participate. But one of the stunning examples, and many people were sent to these halfway houses without attention to risk, is that if you send the individuals with lower criminogenic risk into these settings, they actually did poorer than individuals with low risk that didn't participate. This is a violation of our principal dictum in our field, do no harm. And that what ends up happening is with lower risk individuals mixed in with higher risk individuals, they tend to learn behavior. They are, by definition, hanging around with antisocial individuals, not pro-social friends, and that sort of mixing by risk is associated with these mixed outcomes. As a result of that, the state of Ohio, which spends $125 million a year on these facilities, have employed a systemic risk assessment and now are ensuring that those resources are used principally for those individuals with moderate and higher risk. The risk principle says focus your resources, your criminal justice resources principally on those individuals with higher risk levels. The needs principle says that if you're going to mitigate the likelihood of return to custody, then you should focus on those criminogenic needs that are associated with arrest. So for each risk factor, there's an associated need. If I score high on substance use disorders, I need interventions that are going to reduce my use of those agents. If I am with antisocial friends, I need to find pro-social friends. If I'm having problems with employment, I need to get into supported employment work so that I can work competitively and be engaged in meaningful activity during the day. So that the whole focus of the needs principle is let's not spend a lot of time, if we really are focused on public safety outcomes, intervening on areas that are outside of the central 8 for those individuals that have a specific type or types of criminogenic risk factors and needs. Let's use interventions that are targeted to those needs. That's the need principle. And last is the responsivity principle. Now, we put this slide here in that, as I mentioned earlier, mental illness was not in the central 8 factors, yet is related to all of those factors. And what we talk about now with our new understanding of pathways into jail for persons with serious mental illness is that mental health treatment for mental illnesses are absolutely necessary, but not necessarily sufficient to deal with those other factors that are related to arrest. So if we think about an individual that has been arrested and released recently, not been sleeping, lost a lot of weight, not interested, feeling fairly hopeless, thinking about suicide, meeting criteria for our major depressive disorder, we then want to imagine that individual being assigned to a group to deal with their criminogenic risk. That individual isn't even likely to get out of bed to attend the group, and if attending the group may not benefit from the educational and cognitive interventions that are being delivered. So that treatment for that individual's major depressive disorder is going to put them in a place where they can take advantage of some of the other strategies and interventions that in toto may mitigate their likelihood of return to jail or prison. So we, in thinking about responsivity, have broken it up into 2 principal categories. There's a general responsivity, which refers to the learning styles, culture, ethnicity, the way in which people take information, relates to gender and those experiences that are gender specific. That's the general responsivity. Specific responsivity is where we bring in factors like mental illness, trauma, homelessness, the conditions that need attention and need to be incorporated into our treatment interventions. So that's a very swift review of what risk, need, and responsivity is. It's highlighted again in the primer that we've recently released, and I would really encourage those of you that are less familiar with this concept to actually take a look at the primer that's there. What we know is that we can make a difference on these criminogenic risk factors. In the old days, we might have taken that individual with the antisocial personality label, noted that in Axis 2, and I know when I was in training, we were taught that there was very little one could do for Axis 2 disorders because they were egosyntonic and the individual wasn't motivated and was more bothersome to people around. We all know now that that's not true, and that we've learned with dialectical behavioral therapy for individuals with borderline personality disorder, you can make a difference. You can help people think differently about themselves, and then in response to that, make different choices as they move through the world. So that we have now cognitive behavioral treatment interventions that were developed principally within the criminal justice settings, but they have been shown to reduce the likelihood of people making bad choices and returning to custody. And that these CBT interventions, which employ social learning techniques, are really something that I think we all need to be more familiar with and think about ways in which we might employ them for those individuals that come to us with criminal justice histories. And I know that if you have a clinical practice as I do, the vast majority, all of them, the individuals that I meet with that have spent time in jail don't want to go back there. That's one of their goals, is to avoid subsequent arrest. And so we have things that we can offer them in terms of manualized and research-based interventions. This slide gives you a brief description, and these are all in the primer that's available, and we'll let you know how to get that at the end of the session. But there are several interventions: thinking for a change, reasoning and rehabilitation, moral recognition therapy. These are all structured group interventions that take individuals through decision-based scenarios using peer-to-peer interactions guided by trained facilitators to achieve the goal of better decision-making out in community. And all of these have adaptations for individuals with serious mental illness that accommodate for that responsivity factor that can be employed. The last one in this slide is interactive journaling, and this actually is something that can be done on an individual basis, not a group basis, using material that are produced by the Change Company that give that individual homework assignment that can be reviewed and then allow that individual to rethink the way in which they engage the world while they're out in the community. So that's our R&R, and these are some of the ways in which our understanding of risk, need, and responsivity is driving activity within the field. And at this point, I'd like to talk a little bit more about screening and assessment, because if we don't understand who we are targeting, what the needs of those individuals are, the effective treatment and supervision strategies, supervision in collaboration with our criminal justice partners, are not likely to be as effective. We put this here for your consideration, and that the sequential intercept model is one of the more used paradigms to think about alternative responses for individuals with serious mental illness moving through criminal justice settings. And that it starts at the point of contact, dispatch, call for help, 911, police on the scene. That is intercept number one, what individuals can do differently at that point in time to divert individuals that don't pose a public safety risk from jail, and moves into our jail settings. It is the case that within our jail settings, it is the only group of individuals that have constitutional protections for health, including behavioral health care. It's not our elderly, it's not our young, it's probably not anyone on this webinar. that if you are arrested and brought to jail or you are sentenced and taken to prison, there is a responsibility to screen, assess, and provide a community standard of care for health conditions, including mental illness and substance use. And it's this public health opportunity that we really want to understand and take advantage of through a thoughtful screening process to identify the strengths and needs of this particular cohort. This slide is a framework that was developed in conjunction with partners from the National Institute of Corrections, the American Association of Correctional Administrators, National Association of State Mental Health Program Directors, National Association of Drug and Alcohol Directors. The impetus for this were two systems that were pointing fingers at each other as being not responsive. I'll send you this individual that's been tearing up my jail, and you treat them in the community. Oh, they don't fit your eligibility criteria. Vice versa, we've got these individuals that are really threatening and posing a safety risk. We need you to sort of confine them and segregate them, but they may not meet criminal criteria for that. There was a need to develop a common language, and that's what the output of a year's worth of groups is reflected in this chart. And what we're suggesting as a way in which one then can sort of be more thoughtful about who we target for interventions is to move them through a series of screening and assessment. First, identifying their criminogenic risk level from low to high. These aren't dichotomous variables, but I presented it this way for simplicity. Secondly, because of the high rates of substance use disorders, 65 to 75% of people moving into our jail setting meet criteria for a substance use disorder. We need to understand where that individual sits on that continuum from mild to severe. Then, understanding where they are as it relates to mental illness with an appreciation that there's a degree of heterogeneity and that we have focused this conversation on those individuals meeting state definitions for serious mental illness. And with that screening and assessment information, you can then sort individuals into these groups that are represented on the bottom. On the left side, lower criminogenic risk. That doesn't mean low need. You can still have high substance abuse and mental health need, but lower risk. And for those individuals, using the risk principle, we want to identify what those needs are and connect them to behavioral health treatment in the community. Reserving our criminal justice, probation, parole dollars for folks on the right side of this graphic, which are in the higher criminogenic risk categories. And it's those individuals with behavioral health needs that beg for collaborative responses from our behavioral health and our criminal justice partners. So screening and assessment allows us to define target populations and then think about the appropriate interventions and strategy. How does one screen? How does one sort of assess? There are a variety of tools that we've reviewed within the primer. There are links to each of these tools. If we look at the left side of the column, screening for mental illness in a jail setting, we've highlighted screens and tools that are in the public domain. Not all of these are, but many of them are, so that the costs associated with them are absent or minimal. Screening for mental illness at the front door, brief jail mental health screen, 8 questions, 2 to 3 minutes, delivered by a correctional officer, raises a flag, positive, that means an assessment is required, or correctional mental health screens for men and women. These are examples. We also have provided here examples of substance use disorder screens that are validated for criminal justice population and the criminogenic risk screens that you may need in order to get a clear picture of that individual. The importance of understanding and assessing criminal justice involvement gets back to Dr. Champion's earlier point. Almost a third of individuals that you see that come in through a community mental health center door for evaluation have criminal justice histories. We're pretty good at getting their psychiatric, social, medical, family histories, but that it's really important, and for you that are supervising residents within settings, we need a series of questions that identify whether there's been criminal justice involvement. That isn't something that people offer at early on in their conversation with us. We need to specifically probe about their histories of arrest, their histories of conviction, their status currently, whether they're on probation or parole, whether there are any orders of protection. And with that history, And with that understanding, we then can then think about, oh, does this individual need specific tailored interventions to mitigate their criminal justice involvement? It is the case that many criminal justice agencies conduct criminogenic risk assessments. And so if you have an individual with a long criminal history, there may be information that's available that you don't need to collect yourselves. It is available through information sharing agreements, and psychiatrists may have access to the result of these risk assessments, and that with those, some of the dynamic factors can be identified that may make a difference for that particular individual. It is the case as well that what we would like to sort of suggest is as a set of strategies to limit and reduce the number of people that are unnecessarily involved in criminal justice settings, we want to, 1, conduct universal risk and substance use and mental health screenings, 2, get the relevant information into the hands of decision makers to inform their criminal justice decisions, 3, use this information to connect people to appropriate services, both inside the jail and within our community, and then 4, ensure that the treatment and supervision is coordinated in a way that we can help that individual reach their stated goal of not returning to jail or prison. There is a national initiative going on that I'd like to make this audience aware of if you're not already, with the National Association of Counties and the American Psychiatric Association Foundation. The Justice Center for the last 2.5 years is engaged in a Stepping Up initiative. We have focused on counties because that's the front door to our criminal justice system. We have asked those county commissioners, the elected officials that are interested, to pass resolutions suggesting that the status quo is no longer acceptable. And we call this Stepping Up. It is the case that since the initiative started, we have over 400 counties that are currently enrolled in Stepping Up, working together to use the latest science and research to advance the ability of systems to reduce the number of individuals with mental illness within criminal justice settings. If you haven't heard of this or you'd like more information about it, there is a website, www.stepuptogether, that I would refer you to. This issue is taken on by a variety of groups and organizations. We highlight here a manual that was produced by the Group for Advancement in Psychiatry, the Committee on Psychiatry in the Community. This manual took 3,000 letters that Dear Abby solicited from people and their families that had mental illness in contact with the criminal justice system. It is designed for a target audience of mental health professionals and gives practical tips on how to interact both at the clinical and system level to make a difference. So with that information, I want to move into a Q&A session. We only have a few minutes left, but I'll turn this over to Deirdre.
Thank you so much for your presentations, Dr. Champion and Dr. O'Shea. We are coming close to the end of our time today, but we do have time for one question. So I would like to ask, should cognitive behavioral interventions be administered at the same time as treatment for mental illness, before addressing the mental illness, or after the person has demonstrated remission of some symptoms?
You know, I would say, and I'll be interested in Dr. Champion's opinions on this as well. It's a great question, and the answer is probably going to be less than satisfying. It is no specific pattern or recipe to approach this. One needs to do a clinical assessment of that individual, where they are in relationship to relief from some of the symptoms that are interfering with their mood, thinking, and behavior. At the point that they are able to participate within a group setting, and this obviously doesn't require remission of symptoms, that would be unrealistic, but that we want to make that decision based on that individual's own ability to participate in the group intervention. And clearly with a conversation with that individual about what their druthers are and needs, one can make an informed decision. It is important that once one starts into a cognitive behavioral treatment intervention, that one can attend the groups that are designed and participate for the duration of it. No one answer to that good question. That would be my take on it.
Sure, and thank you very much. That's a great answer. I want to go back to highlighting the issue of responsivity, that wing of the R&R principle. One thing that I hear frequently is, excuse me, individuals saying, well, if somebody has a severe mental illness and they're having active symptoms of mental illness, I don't know how I'm going to do a screener for criminogenic risk or do these interventions. And so I think people historically have set the screening and the intervention aside, hoping that that just treatment of the mental health symptoms, as psychosis, agitation, cognitive disorganization that comes along with severe mental illness. If treatment addressing those symptoms, then they'll get better and criminogenic risk will go down. But as Dr. Osher outlined, that's the literature base just doesn't indicate that. And so active symptoms of mental illness are a responsivity factor. So if somebody is actively depressed or agitated or psychotic, they're not going to be able to absorb the cognitive behavioral interventions, either in an individual or group setting. So I think that they do need to happen in parallel. The key takeaway is, and certainly titrated as tolerated with intervention to reduce the active symptoms of a psychiatric illness. I think the key takeaway is screen, know what the factors are, and weave them into treatment planning, whether they're going to be delivered by the treatment team or in partnership with criminal justice partners, and then also know that it's important to reduce the active symptoms of a psychiatric illness so somebody can engage in those interventions.
Great. Thank you so much for your answers. We have come to the end of our time today. We encourage you to reach out to the panelists with any additional questions that we were unable to answer this afternoon. I'd like to thank everyone who took time out of their day to join our webinar today, and especially thank our 3 panelists for presenting the information. If anyone would like additional content like this, please sign up for the JPLI newsletter. We will have the link to that available for you as well. Thank you, everyone.
Thank you.
Thank you.